renewing and adapting prescriptions is something that is a bit of a niche for us as well. So we talk about patients with chronic conditions and they're stable. And for example, the patient can't go see the doctor for that week. The appointment is next week, they need to get assessed, and instead of gingerly advancing medication, which I've done before prior to 2012 because I didn't want my patient to be out of medication, I can actually extend that prescription. I can renew that prescription for a period of time until you're able to be assessed, or even beyond that depending on your condition. Of course, all this stuff has to be communicated with your prescriber, so it's not done unilaterally, it's not done without questions, it's done with an assessment. So there has to be an assessment that has to take place. I wanted to mention that the pharmacists aren't obliged to give you a renewal. We do it because we want you to make sure that you're okay, and we want to make sure that the assessment is done in the first place. If you need to see your doctor, for example, your blood sugar is very high, we want you to go see your doctor, so we may not extend that prescription for as long, because we want you to see your doctor, because they can do certain assessments that we cannot. We want to, as pharmacists, we want to urge you to not go to the pharmacist and avoid your doctor or your nurse practitioner. We're not taking place of your doctor. Your doctor can do assessments, lab work, tests that they need to do. So seeing your prescriber is very, very important. That's why I want to put it up there that don't avoid them. They're there because you need them as well in your healthcare team. The very last part of this is adapting prescriptions. Adapting prescriptions means that if the doctor's prescribed you a therapy that you can't, for example, ingest because you have swallowing issues, adapting that prescription may mean changing it from a capsule form to a liquid form. Or for example, if the regimen isn't correct, and this goes back to a story that I have of when I was working a relief shift at a pharmacy, and it was about 10 p.m., and most physicians would have gone home by then. But I got a prescription for a little kid, not an infant, it wasn't even a toddler. And it was an antibiotic for an inner ear infection. But unfortunately, that doctor had misdosed that child. At 10 p.m., unfortunately, we couldn't clarify anything. So that was before 2012, so I couldn't change those directions. I had to dispense as written, and then gave her a separate piece of paper saying, don't do this, don't follow the instructions on the bottle, follow the instructions on my piece of paper, and this is the correct instructions, and we'll clarify it tomorrow when we can reach the doctor. Now, I don't have to do that anymore. I don't have to wait until that clarification because I can send a assessment of the situation and say, this is not the right dose for this child because of X, Y, and Z, and send that to the doctor. Obviously, there's certain things we can't do. There's certain things that we're restricted to. For example, if it's really not our place to change it, if it needs to be clarification, if the dose seems very high but there may be indication for it, then we want to make sure that we clarify that before we give that to the patient. Everything is done with documentation, so we're not just doing it for the sake of doing it. But the last thing I want to mention about adapting prescriptions is if you ever pick up your pill bottle, do you notice where the doctor's name is on your pill bottle? Right? So if you see that your pharmacist's name is on there, it's most likely because they adapt that prescription. If you have any questions about that, make sure you call me. The phone number should be on the label too. So if you have a question about, well, what changed with my prescription, and I don't see my doctor's name on there, just call. They can probably tell you why. Okay? Moving on to the administration of injections or inhalation for education and demonstration. So as a pharmacist, you can't come to us and get every single dose of an injection done, but we can actually show you the very first one and for you to be comfortable with actually getting that injection in the pharmacy before you go home and have to do it yourself. Same thing with inhalers, same thing with anything that is demonstrations or glucometers, things like that. I remember back in the day when I had to verbally instruct someone how to poke their finger so they can actually test their blood sugar because I wasn't allowed to do that for them. And they just couldn't poke their finger. They just kept, they would poke it, and then before they pressed the button, they would move their finger out. And I couldn't poke it for them, so I had to hold their hand, and as you can feel it trying to move, but it's one of those things where just let me do it for you to show you how to use it. So it's one thing that I'm very passionate about, because if you don't know how to use your meters, if you don't know how to use your inhalers, your devices, you're not getting the medication, you're not getting the monitoring that you need. So that's why it's so important to do so. Flu shots. I'm not going to ask who got their flu shots because it's a personal thing, but as pharmacists, we now can vaccinate for the flu every single year. And at our pharmacy here in N1, we have flu shot clinics starting in October and usually runs every day until probably close to December, early January. And the reason why is because we feel that the flu shot is very important to get, especially for people who are in the hospital, who are usually a little sicker than those that stay in the community. As of December 15th, we also expanded that scope of practice to include other vaccinations, including travel vaccines and herpes zoster, so the Shingrix, for example, everyone's talking about. Some of these vaccines are covered by OHIP, so coming to the pharmacy means you may have to pay for them. So be aware of that and ask your doctor if it's OHIP covered or not. If it is covered, then you may want to get it from the doctor's office. Last but not least, this is not really part of the expanding scope of practice or the expanded scope of practice, but I have a lot of people asking me, what's a compounding pharmacy? How many of you have been to a compounding pharmacy? Very good. That's more than I expected. So it's not an expanded scope of practice, but all pharmacies can compound minimally for you. So menthol and camphor and some kind of cream for you so it helps with itching and rashes. But there's more and more things that they can make. So for example, if you need a special dose of a pill that you really just can't split into eighths. I don't know how many of you have tried to split tablets into eighths, but it's very difficult. You start getting crumbles and you just try to pick up little bits and pieces trying to make up the eighth of the tablet. So what compounding pharmacies can do is make that tablet into an eighth of that dose and put it into a capsule for you. And that way it's a lot easier to use. For kids, for example, who really just can't tolerate taking liquid medication, they can make it into lollipops. And who doesn't like a lollipop, right? So they can take the lollipop. There's also a lot of different compounding pharmacies that can tweak different formulations and make creams for you, make lozenges for you. So just want to let you know a little bit about what compounding pharmacies are. And if you do need one, at least we know that there's quite a few in the GTA area. Excuse me. This past week, just this last week, was Pharmacist Awareness Week. And the month of March is actually Pharmacist Awareness Month. These are just a few images for the things that we can do. The very last one, in terms of prescribing for minor ailments and conditions, is not something that we can do here in Ontario, but it has started in BC as well as in Alberta. So hopefully eventually I'll move this way as well. And think pharmacists, because there's about 41,000 of us in Canada. And if you're in Toronto, you probably have a lot of that number within the GTA. We also have pharmacy technicians in Canada, and Tricia is going to be talking about that a little bit later. So we're very accessible. So we want to make sure that you are aware that we are part of your healthcare team, and use us to the point where, as references, as people to answer your questions, and as a point of entry into the healthcare system. That concludes my part of the presentation. Right. So for those who have questions, in terms of writing questions on the cards, please do put your hand up with the question. And well, I can't take the question right now, but if you write down the question, we have volunteers in the back who are going to actually collect the questions, and we'll answer them at the end. All right, I would like to take this opportunity to introduce Trisha Damhat. She is a registered pharmacy technician here at Sunnybrook. She works with me in M1 Pharmacy, and I would like to welcome her to the podium to discuss avoiding medication misuse.
Thank you, Karen. Good evening, everyone. As Karen mentioned, I work in the outpatient pharmacy. I've been working there for about 2.5 years now, and I am one of 2 technicians that work with the blister pack program, which I'll talk about a little bit later. Today I'm going to talk to you about the role of the pharmacy technician in avoiding pharmacy misuse, medication misuse. So before we get started, I thought I'd tell you about what a pharmacy technician does within the pharmacy. So we work alongside pharmacists to provide direct patient care. Technicians are able to help with the technical aspects of filling your prescription, whereas the pharmacist handles the therapeutic care. For example, we're usually the first one you meet when you come into the pharmacy. We're usually at the reception desk or the prescription pickup. We're there to help you answer any questions, and if we can't, we direct you to the pharmacist. For example, if you're looking for an over-the-counter medication and you need a recommendation on which one to use, we would direct you to a pharmacist like Karen. As the pharmacist's scope expands, so does the technician's scope. Pharmacists are becoming more busy helping patients continue their therapies, so there is a little bit of a gap. The technicians are able to help fill that gap. Karen mentioned that the pharmacists are there to help teach you how to use your devices. Technicians are now able to teach you as well. If you are the first time you're using a spacer or an aero chamber with your inhaler, a technician can show you how to help you, how to use that medication if the pharmacist is busy. In the M1 pharmacy, we also have a technician that measures compression stockings. While this is not something unique to a pharmacy technician, it is an area that we can help you with as well. At Sunnybrook, we have best possible medication history technicians. These technicians are working in the emergency room to help gather information about your medication history. This is a great tool for avoiding medication errors. We gather information through multiple sources about your medication history to provide to the healthcare team. This helps us identify problems or avoid duplicating any therapies you've previously been on. Technicians are now able to help check refilled prescriptions. There are some limitations. The pharmacists are always there to help if we think a patient may have an adherence issue, or if the medication is a new therapy added to their current regime, or if it's a narcotic or controlled substance. A pharmacist must always check for therapeutic effectiveness of all medications and check for potential interactions. This function helps in the blister pack program. Blister packs come in many different forms. This is an example of a 4-dose blister pack. So we have the morning slot, the noon slot, the dinner slot, and the bedtime slot. There are 2 doses, and there's also just a single dose. They're usually in the form of a week. This is a great tool to help you avoid medication misuse. It groups the medications according to when you should take it. It eliminates having multiple vials of medication, making it easier and less confusing. Anyone can use a blister pack. It's not geared to a certain population or another. Anyone with a complex regimen treating chronic conditions such as diabetes, hypertension, or dialysis treatment can use these. Blister packs may also be helpful for patients who are unable to take medications on their own and have family members or caregivers that are helping. Pharmacists work closely with the technicians to create these blister packs. They're usually a meds check done before these packs are created and started, and and they always help with the therapeutic care of medications. So how does this help medication misuse? Well, it's going to create a little bit of organization for complex regimens. It's going to give you an easy way to take your medications. It's going to prevent you from taking more of your medication or less than your medication than prescribed by your physician. This blister pack also comes with a chart attached. This chart will help caregivers correctly identify the medications in each slot, and as well, in emergency situations, it's easy just to grab the one pack instead of multiple vials to show you to your emergency team. Since all medications are grouped together, the pharmacist can also alert you to separate medications correctly. For example, medications that need to be taken at breakfast with food or before breakfast on an empty stomach, like your thyroid medication. In summary, technicians can do a lot to help you. If the pharmacist is ever busy, a technician is always there to try to help answer your question. If we can't, because it's out of our scope, we will direct you to a pharmacist. As the scope of practice change, technicians are able to do more to help you, and we're always ready and willing to help. Thank you.
Thank you so much, Tricia. I hope you have learned a little bit more about what pharmacy technicians can do for you. Just as a reminder, I have some questions already, which is great. If you have any additional questions, raise your hand up with the card, and our volunteers will come around and collect them. I'll now introduce our next set of presenters. They're presenting as a group today. They will be here as a group discussing antibiotics and how to use them properly. Michael Wan, Jennifer Lowe, and Marian Ellickson are all antimicrobial stewardship pharmacists. If you don't know what that is, they're going to probably tell you a little bit about it. Please help me in welcoming them to the podium.
Good evening, everyone. Thanks for having us tonight. Can everyone hear us clearly? I see nods at the back. I think we're okay. So again, my name is Michael. This is Jennifer. This is Marian. The three of us form the pharmacist-led antimicrobial stewardship team here at Sunnybrook. I know that's a bit of a mouthful, but I think by the end of this, you'll know what we do and know why it's important. So we're here to talk today about, unsurprisingly, antibiotics. The right antibiotics, when you need them, and when it's best to take them. So first we'll start off by talking about what are antibiotics, and that leads into what is antibiotic resistance and why are we concerned about that, and what we're doing about that here at Sunnybrook as part of our stewardship team. And then lastly, Marian will give you an overview of common scenarios, what to look out for, and how you can possibly help out as well. So what are antibiotics? Can I get a show of hands? Who here has taken an antibiotic before? I suspect it's going to be everybody. So as we know, antibiotics are very important medications that we use to treat infections caused by certain germs. Some, most commonly bacteria, sometimes parasites. They don't work against all infections though. So think of things we commonly get, the common cold, the flu. Antibiotics don't work against infections caused by viruses. And it's been amazing to have these medications around. Penicillin, which is the first antibiotic, was discovered in 1928, and it's revolutionized medicine since. And it's only been less than 100 years since we've had them, but it feels like a lot longer because they've done so much to advance modern healthcare for us. So unfortunately, bacteria are really smart. These critters figure out ways to get used to antibiotics. So there are lots of germs around, and so if we start on the left side of this diagram, we have lots of germs. A couple of them are smart. They've grown, they've evolved, they've adapted to become resistant to antibiotics. But there's not many of them. There's just one or two hiding in a couple corners. They're not really doing much. But what happens when you take antibiotics is you kill all the other bacteria. That's good. You're treating the infection. This is a good thing. Once in a while, though, if this happens too much or for too long, The bacteria that are resistant, that were hiding in the corners, now they come out and they say, hey, I have no competition, I've got all the food I want, all the space I want, and they grow and they multiply and they take over. And now you have bacteria that are resistant to that certain antibiotic that was used. To top things off, bacteria, sometimes they can talk to each other and they'll exchange their tips and their tools and teach the other bacteria how to be resistant. They're really smart. This doesn't happen too often, but when you start to use antibiotics more, it happens more, and that's why we work hard to do what we do. And eventually, if antibiotic resistance is not granted, if you can imagine, we might have antibiotics, but the bacteria, they're not susceptible, the medications don't work against them. Thankfully, today in Canada, the issue isn't too bad yet. However, we can look around the world. In some other countries, they have much bigger issues, and treating infections there is much more difficult than here in Canada, and sometimes I even take that for granted. Infections that we consider easy to treat could be deadly just because we have no medications that work. And for example, we think of a surgery that we all needed to have. When they cut you open, you don't get an infection of the skin because we clean the skin and we give you antibiotics to prevent that. But as you can imagine, if antibiotics can no longer prevent that, that would make having surgeries much more difficult than before. This is something published by the World Health Organization. It's a bit of a complex diagram. In the light blue, it's their yearly estimate of deaths caused by these various causes. Unsurprisingly, cancer causes very many worldwide, 8.2 million, traffic accidents at 1.2, etc., diabetes at 1.5, and currently they estimate that antimicrobial resistance contributes to around 700,000 deaths a year, so that's already a lot. What's very worrisome is as bacteria learn to be more and more resistant, the World Health Organization estimates that this number will jump to 10 million by 2050, and that's a huge number. And the thing about it is, though, we can prevent this if we all work together. Just to take a sidestep from talking about antimicrobial resistance, just to talk about side effects. And we all know all medications sometimes have side effects, but the benefits usually outweigh them as long as we use them carefully and we choose them properly. The common side effects include stomach upset, diarrhea, a rash that's not very bothersome, but in very rare circumstances, you can have allergic reactions. There's also C. difficile-associated diarrhea. This is different from regular diarrhea because C. difficile is the name of a bacteria. It's one of those resistant bugs that hangs out. There's not very many of them, but when you take too many antibiotics and there's not too much competition, they start to grow and they cause this really annoying diarrhea that's caused by a bacteria and can sometimes be quite dangerous. Lastly, we've all heard about taking probiotics or taking care of the good bacteria in our gut. We wouldn't be able to live if it wasn't for the bacteria that we work with every day. But antibiotics, if you take too much, sometimes you might affect that. There's a lot of research going on into how you can make sure the good bacteria are with you, but possibly taking antibiotics can affect that. And then lastly, you might be thinking, so we come up with new medications all the time. Why can't we just keep bringing out new antibiotics to address this? So new antibiotics sometimes come as intravenous only, so they can't take a pill. You have to put an IV line in, which is inconvenient. They're often very expensive. They sometimes have more side effects because now you're willing to accept more side effects to treat a more resistant bacteria. And as a result, they might target more organisms and potentially lead to resistance a little bit quicker. But the most important part, aside from all of these reasons, is we just don't have very many. You look at all the antibiotics coming out in research and being developed, there's not very many, and so that's what's a little worrisome for us. But enough about the downer talk. Let's talk about what we can do about that. And so what we do is we look at whether antibiotics are prescribed appropriately. We don't say don't use antibiotics. We don't say use them all you want. We say we use them in the best way possible when you need them. In Canada, we know there's 25 million antibiotics prescribed each year. That's almost one for every citizen of Canada. but some estimates think up to 30 or 50% of those are unnecessary. And it's tough sometimes, you're not sure if it's an infection, sometimes you might use it for too long to be safe. It's tricky, but we know that overuse contributes to resistance, and that's why we're here to help. I'll pass it over to Jen, thank you.
Hi everyone. So what can be done to help? I'll take the next couple of minutes to tell you a little bit about the antimicrobial stewardship program at Sunnybrook. Our program has actually been in place for almost 10 years now. Here we have a picture of our team. Our team includes pharmacists, doctors, as well as specialists in infection and prevention control. Importantly, I want you to be aware of this team so that when you are at Sunnybrook, and if you are on antibiotics, you have an impact on the antibiotics that you are on. Our goal is to ensure that antibiotics are used appropriately in order to achieve the best outcomes and to limit unwanted consequences for our patients. So this includes appropriate treatment of infection, if there is an infection, which will lead to improved patient outcomes as well as improved patient safety. We want to, again, limit the unwanted side effects, and we want to limit the antibiotic resistance that Michael previously talked about. So what exactly do we do? Our antimicrobial stewardship team reviews antibiotics for patients who are admitted to Sunnybrook Hospital. This includes the Bayview Campus, the Holland Center, St. John's Rehab, as well as the Veterans Center. We look at the choice of
Please, your attention please. Code Omega, A Alpha Wing, ground floor, emerge, trauma. Your attention please, your attention please. Code Omega, A Alpha Wing, ground floor, emerge, trauma room, Bay 2.
Okay, so we look at antibiotics for patients who are admitted to Sunnybrook Hospital. We look specifically at the choice of antibiotic, the dose of antibiotic, as well as the route of administration. We work very closely with your main team to ensure that we have the best antibiotic care plan in place. Additionally, we are also involved in research as well as teaching as it relates to antimicrobial stewardship. In the past years, we have achieved decreased antibiotic use in both the ICUs as well as the hospital wards. We have also decreased the rate of hospital-associated C. difficile diarrhea. And additionally, we have decreased the amount of resistant bacteria that has been isolated in our patients. These are all very important in ensuring that we have good patient outcomes at Sunnybrook. And I'll let Marian talk to you next.
So finally, we've been talking a lot about antibiotic overuse and perhaps antibiotic misuse. I'm just going to give you a couple examples of when this does occur. We all acknowledge that antibiotics are life-saving and they're necessary for a lot of patients in our hospital. But there are some scenarios where prescribers can perhaps pare back on their prescribing and preserve antibiotics and antibiotic exposure in certain patients. So the first one being respiratory tract infections. So Michael had mentioned that antibiotics kill bacteria. But unfortunately, a lot of our respiratory tract infections are actually caused by viruses, which are not impacted by antibiotic use. So viruses cause things like colds. The flu is also a virus. Most sinus infections are caused by viruses, bronchitis, and sore throats that are associated with runny nose, hoarse voice, cough, are also typically caused by viruses. So prescribing antibiotics in these settings do not improve patient outcomes and actually just put patients at risk for the adverse effects associated with antibiotics. It's important to note that not all respiratory tract infections are caused by viruses, and in certain situations, your doctor may decide to treat you as either a bacterial pneumonia or perhaps a strep throat. So in bacterial pneumonia, a patient often presents or can present after a viral infection. We know that viruses do set you up to become more likely to develop a bacterial pneumonia. So in this setting, you will initially get better from your viral infection, but then have a sudden worsening in your symptoms, which should prompt you to see a healthcare practitioner to get things sorted out. These symptoms usually include a very bothersome cough, colored mucus, high fever, shortness of breath, and chest pain with deep breaths. And your physician can sort out whether or not you have a true bacterial pneumonia, often based on physical exam, listening to your chest with a stethoscope, and doing a chest x-ray. Strep throat is another respiratory infection that does require antibiotics. And strep throat is different from the sore throat that you get associated with a cold, because with a cold you get a runny nose and often a cough as well. But in strep throat, it's just an isolated sore throat. And these patients often do benefit from treatment. And your physician can actually do a throat swab to determine if that is the actual cause of your symptoms. Another frequent cause of antibiotic overuse is the treatment of asymptomatic bacteriuria. So asymptomatic bacteriuria is the presence of bacteria in your urine, which is not causing infection. We know that urine cultures are very easy to obtain, and they're often obtained for maybe not the proper indications, so for foul-smelling urine or cloudy urine. We know that elderly people are often colonized with bacteria in their urine, and this does not actually impact their health. Treatment of this bacteria in their urine when they do not have infective symptoms will not prevent future urinary tract infections, will not help with bladder control, and will not help with memory problems or balance that is sometimes associated with a positive urine culture. Positive urine cultures without symptoms should only be treated in patients that are pregnant or people who are undergoing urological procedures, so like having a prostate biopsy or having a kidney stone removed. And in these patients, they're often screened as an outpatient prior to the procedure. So contrasting asymptomatic bacteriuria, so where you have bacteria in your urine but no symptoms, with a true urinary tract infection, is based on these symptoms. So a true urinary tract infection, you will know you have a urinary tract infection. These patients present with burning when they urinate. They have a strong urge to urinate often. It's often associated with fever, chills, or confusion, usually associated with back pain when we think of an upper urinary tract infection. So what can you do as a patient? In all of these settings, and when your prescribers initiate antibiotic therapy for you, it's to be open to the discussion of whether or not you do truly require antibiotics, or whether or not this could be due to a virus, or this culture or represents something else other than infection. So that's all we had for you today about antibiotic stewardship. So thank you very much.
Thank you so much, Michael, Jennifer, and Marian. Hopefully you've learned a little bit about what these pharmacists do for you in the pharmacy, in the hospital, sorry. And if you do have questions after that presentation, write it on those white cards and stick your hand up in the air and our volunteers will come pick them up. Now I'd like to introduce our final presenter for this evening. Dr. Sharon Dome is a family physician here in Sunnybrook's Department of Family and Community Medicine. We are truly grateful. She's here to discuss best practices as a patient. Please give Dr. Dome a warm welcome.
Okay, everybody can hear me, I assume? All right, so I've been asked to talk to you about what you can do as a patient and what your role is in helping to facilitate your own medication safety, adherence, etc. So I've come up with a few rules that I'm going to go through. Maybe rules isn't the right word. A few practices that you can go through that you might want to think about when you're dealing with your own medications. So the first thing is know which medications you're taking. And I'm going to go through all of these in detail. Know why you're taking these medications. Keep track of all of your refills. Helps not to get charges from your doctor's office too. Take your medications regularly. Be honest with your physician in terms of everything that you're taking, because oftentimes people are taking things that we don't necessarily prescribe. And it's great to be informed, but you don't want to be misinformed. And I'm going to explain what the difference is between those two things. So the first thing I'm going to do is, this is a complicated diagram, and I want to explain what I mean by all of this. So how many of you in here have only ever had prescriptions given by one physician? Very few. All right, that's what we expected. So I'm just going to walk you through a scenario that I'm sure many of you can relate with, and if it's not necessarily you, somebody in your family or one of your friends. Patients, the bottom line is patients are seeing multiple providers. So even if you have one family doctor, you probably have a specialist or two. You might have gone to Emerge, you might have had an inpatient stay, you might have had surgery, and at each of those sort of touch points with the healthcare system, you might have gotten some prescriptions. And sometimes you go to one pharmacy. So let's say you go to your family doctor's office, you go to your typical pharmacy that you normally go to. And then one day you might have gotten admitted, you go to the hospital, you get discharged, you give your kid the prescription to get filled because you're not in shape to go to the pharmacy yourself, and your kid goes to the pharmacy that's close to them, and then brings you the pill bottles, and you're grateful to get the pill bottles, but now your regular pharmacy doesn't know what you were actually prescribed in that hospital stay. And then another time you might actually go to Emerge, and you get discharged at 2 in the morning and your regular pharmacy's not open. So now you go to another pharmacy. So the bottom line is, I'm just trying to illustrate that there are lots of different touch points with the system, and the point is that the person in the middle is you, and you're the one who actually knows best what medications you've been prescribed and what you're taking. And it's really important to keep a hold of that and make sure that you have all that information so that you can share that with all of the members of your healthcare team. Why is it important to know why you're taking the medications? The bottom line is there's duplication, and what I mean by that is there are some medications that treat different conditions. And if you don't know why you're taking the medication, and then you go into Emerge, and they say, well, what are you taking? And you don't know why you're taking it, they may think you're taking it for one reason, but you're actually taking it for another reason. There are some medications that are long-term, there are some that are short-term, but sometimes people end up staying on their short-term medications long-term because they don't realize they were supposed to stop. And the opposite also happens. People get a prescription for something for 3 months. It could be a blood pressure pill from their doctor, and we see it all the time. And they come back in to see the doctor after 4 months, and they stop taking the drug after 3 months. Well, you only gave me a prescription for 3 months, doctor. Why was I supposed to keep taking it? Okay, it happens all the time. There are certain medications also that are prescribed by different doctors, as we talked about before. And at the end of the day, you guys are the central people. So you need to keep track. Knowing why you're taking your medications is crucial. How can you keep track of all this information? Sometimes it's a lot. When you go to the pharmacy, they give you a list. But when you look at the list, it looks like it lists all your medications. It actually lists what they prescribed to you recently. So it's not necessarily a comprehensive list. You might have stopped some of the things on that list. You might have gotten things from another pharmacy, as we discussed earlier. So you need to make sure that you have some way of keeping track of all of your medications. And the things that are important to keep track of are the name of the medication. Now, how many of you guys have been confused by 2 different names for the same medication? Right, I get confused too. So the bottom line is all medications have what we call a trade name, which is the drug manufacturer's name, and a generic name, which is the actual chemical name of the medication. So it's important to keep track. We don't care which one you keep track of, but you ought to keep track of one of them. And I've had patients come into my office with one bottle having the trade name of something and the other one having the generic name of something, and they think they're taking 2 different pills, and they're actually taking double what they're supposed to be taking because they haven't figured it out. I don't blame you guys. It's hard to keep track of that stuff, but you need to make sure you've got that list. On that list, you want to keep track of the dosage of the medication you're taking. How much are you supposed to be taking? It can be easily in a chart. How often are you taking it? Why are you taking it, and who prescribes it for you? Okay, that's also an important thing to keep track of. I don't know how many of you use smartphones, but there are all kinds of apps you can get to put on your phone if you are somebody who uses a smartphone, that you can keep track of all this. At the end of the day, you can keep track of it on a piece of paper. Whatever way you come up with to be able to keep track of it is fine, so long as you have some kind of a system. I'm sure many of you have had the experience where you go into Emerge, they ask you what meds you're taking, you can't remember, my bottles are in my bathroom at home, doc, I don't know where they are, and you don't have a list. It's tricky, and that's where medication errors can start to happen, because when you come into Emerge, you might get admitted, you don't know which medications you're on. It's hard for the doctor that's seeing you to necessarily replicate your list. And you can say, well, here's my pharmacy, and you give them the number, and they can try and call the pharmacy, but you forgot to tell them you have 2 more pharmacies. Okay, I have people coming into my office say, well, I want to take these medications to this pharmacy, but the little blue pill I'm taking to a different pharmacy. All right, keep track of your refills. How many of you have got stuck with a bill from your doctor's office for a telephone prescription lately? Oh, you're lucky, it's only a few. Okay, I'm surprised it's so few. The bottom line is, it's really important that you keep track of your refills. When you actually get a medication filled at your pharmacy, there's a little number on it that tells you the number of repeats. So the first thing you should do when you get a prescription from the doctor is look and see how many repeats they gave you. And when you get the bottle, check to make sure that they were recorded accurately. Okay, sometimes that doesn't happen, not by our pharmacists, but some of them out there. So you want to make sure that your refills are accurately recorded. When you pick up your last bottle and the refill says 0, so there's no more refills left, that's the time to say to yourself, okay, I've got to go to my doctor's office and get a prescription for this medication. Physicians don't want to sit there and bill you. That's not our intent. We want to make sure that you get your prescriptions repeated when you're actually at a visit, and we usually give you enough to last until you're next supposed to come back, sometimes longer. The problem is people don't always keep track of it. And what we can keep track of is how many repeats we've given you. What we can't keep track of is when you actually took that to the pharmacy, because we have no way of knowing that. So if you come and see me today and you say, well, doc, I'm going to be running out of my prescription, and I can see that you should be running out in the near future, I give you a prescription, but you might not take it to your pharmacy till June, right? It sits on your bulletin board for 3 months because you still have some left, and then you take it in June. So if I give you 3 months, I think it's going to run out in June, but it's really not going to run out till September. So it becomes a little bit tricky. So the bottom line is you need to keep track of those things. And it's really important that you have a system for keeping track of it. There are some pharmacies out there that actually have automatic fax refill systems. And you can get stuck with those too, because what happens is the pharmacy keeps track. As soon as they give you your last bottle and there are no refills left, they then fax the doctor's office automatically, not knowing that you've got an appointment the next week at the doctor's office. So we get those fax refills, and then we all of a sudden think, well, why are they refilling this now? They're coming in next week. What am I doing this for? And sometimes we change the dose. So what happens, the pharmacy sends a thing, we fax in a repeat. Sometimes we don't realize you're coming in a week or two. And then you come in, we change the dose, and all of a sudden the pharmacy thinks you're on one dose, then we're giving you another dose, and it gets quite confusing. So again, keep track of your refills, make sure you've got a system for being on top of those things. Take your medications regularly. Why is this important? I think the pharmacist went over some of this already. But you need to figure out a way to remember to take your medications. Blister packing, Tricia talked about that. Obviously a very good way if you're on a complex medication regime or you just have difficulty remembering when to take your meds and whether or not you've taken them. The manufacturers of birth control pills came up with a really good system, and I don't know how many of you ever looked at those, but they have little stickers on them so you know what day you took the pill. It's smart. We don't have that with the rest of our medications. We should, but we don't. So the bottom line is you need to have a system, and sometimes we forget, right? Especially when you're a complex medication regimen. Did I take it this morning? I can't remember. You need a system. So again, I go back to the smartphone. If you're a smartphone user, there are lots of good apps you can put on your smartphone that allow you to keep track of your meds. It'll even remind you when to take your meds, or you can blister pack, or you can get a dosette, or if you're only taking one pill, you put it somewhere where you know you're always going to remember. Again, figure out a system. And if you're the caregiver for somebody who's on a complex regimen or has difficulty remembering them, you too can use that kind of a system to be able to keep track of things. be honest with your healthcare system team. And what do I mean by this? I'm not implying that people are dishonest. I'm just saying that sometimes patients don't tell physicians things because they think they either aren't important. So for example, I'm taking my Advil every day for my knee pain, but it really doesn't, it's an over-the-counter thing, it doesn't matter. And they don't tell the doctor, and that happens all the time. And there are actually interactions between things that you can get without a prescription or over-the-counter things and prescription medications. So we do need to know about all of those over-the-counter, non-prescription things that you take. Sometimes people are taking naturopathic, homeopathic remedies, etc., and also don't share them with us. We need to know what's going on. And it's really important because when we're giving you advice to help optimize your health care, we do that with the information that we have. But in order to provide you the best advice possible, we need to have all of the information. Sometimes people just don't take their pills, and they're afraid to tell the doctor, right? We can see this. So either your blood pressure is way higher than it should be, or somehow I gave you 3 months of your prescription a year ago, you're taking it every day, and now you're still here a year later, and you've only used 3 months of your prescription. It doesn't add up. Tell us what's going on. We need to know the facts. You know what, the docs aren't going to be angry at you, we just need to understand what you're actually doing, again, in an effort to provide you with the best information possible. So for example, if you come in and you say, well, I'm taking my blood pressure pill every single day, and your blood pressure is high, we're probably going to add a pill. If the truth is you just weren't taking what you were given, I'm not going to add a pill. I'm just going to say, okay, probably what are some strategies we can put in place to get you to actually take your medication, because I'm concerned about the long-term effects on your heart health of not taking your blood pressure medication. So again, be honest. If you don't want to take something, or you don't believe in something, or your neighbor's kid died of something because of the medication, you're worried about it, tell your doctor. Okay, make sure that we know what's going on. When I say be informed, not misinformed, there's lots of information out there. How many of you look things up on the internet before going to see your doctor? How many talk to your neighbors and your kids and everybody else to get their opinions? How many people get opinions they don't solicit? Okay, so all of us get information from all kinds of places. When I go to see my doctor, I look things up too. So we all want to educate ourselves, and it's great to be informed. And physicians like their patients to be informed, we just don't like them to be misinformed. And what I mean by that is this, that there are sources of information on the internet that are fantastic. They're based in evidence, they're factual, they're reputable, and those sources of information are great. There are also lots of sources of information on the internet that are not so good. Anybody can post things on the internet and make it seem like it's factual and that they're knowledgeable. But it's not always the case. I can tell you I had a patient come to my office, this is in a pre-internet era, probably some 15 years ago, and she was didn't believe in vaccinations, and she came to me with a book with all these little yellow stickies in it. And all the little yellow stickies were the things she wanted me to read about why vaccines are bad. And the first thing I did was go to the biography of the person who wrote the book. And she said, oh, no, go to the yellow stickies, she says to me. I said, well, before I read the yellow stickies, I need to know if I'm going to listen to anything the person that wrote the book is going to say. And it's really important, and she looked at me like I was a little crazy, but that's truthful. And you need to do the same with the internet, because it doesn't take a genius to put something that looks very official on the internet, although they don't have the credibility to be putting that kind of information there, and people still believe it. So look at reputable sources. I think it's pretty easy to, if you actually look at it with a bit of a critical eye, to figure out what would be a reputable source for something. And if you're not sure where it would be a good place to look for information, certainly ask your physician or somebody in your healthcare team in terms of what they would advise in terms of the type of information you're looking for and where you can find factual information about the subject that you're looking at. And I've also got in here, one person's experience does not translate to another. And what I mean by that is as physicians, we're trained to look at scientific evidence. And what that means is we don't look at the side effect that one person had. We look at the side effects that lots of people had. And when we give you advice, it's to say, okay, a small portion of people had this or that, but the vast majority didn't. Everybody brings their experience to the table, and obviously if you know somebody who's had a particular side effect or something, it's going to jade your opinion of how you look at something and whether or not you want to take it. But just bear in mind that your one instance is one instance. And it doesn't mean that that is reflective on the whole category of medications. Okay, so we've all had friends who've had a side effect to something or something else. But again, don't let that jade everything that you think about a particular class of medications. So again, I think we've gone over all these best practices, and I think the take-home point here is you as the patient are at the center of your healthcare team. And in order to get the best advice that you can possibly get, you need to be able to follow all the rules, make sure that you're taking charge of it, make sure that you keep lists of everything, and if you feel that you're not able to do that, solicit somebody in your family or a friend to help you organize your things so that you can keep on top of your medications. Thank you.
Thank you very much. One more question was about Is it necessary to take antibiotics prior to a dentist appointment for regular cleaning?
Hi everyone. So the question was, is it necessary to take antibiotics prior to a dental cleaning? It depends on the dental procedure and it depends on your medical history. So for certain populations, certain people who have had maybe previous infections with their heart valves or replaced heart valves, if you've had previous procedures, you may be at risk for developing infections if bacteria get into your bloodstream. So for certain dental procedures, you may require antibiotics. You should talk to your dentist as well as your doctor and to figure out whether or not you should be taking these antibiotics.
I'd just like to clarify, for most dental, so for routine dental cleaning, if there's no breakage in the skin or the gums, so not the blood exposure is minimal, you don't need antibiotics, and these are in guidelines and whatnot. It's for the bigger procedures. But again, talk with your doctor about your risk factors and go from there. But usually for a routine clinic, even if you have a history, you usually don't.
Thank you. This one is for Dr. Doan. Are you winning the battle against invasive strep A infections? I don't know if that's very specific yet.
So the question was, are we winning the battle against invasive
Strep A infections.
I think that's for the microbial stewardship team.
Well, then we'll go pass it to you guys.
So it's a difficult question. We still see, unfortunately, patients admitted to hospital due to invasive group A strep infections. I can't say that we're necessarily winning the battle, but the good thing about group A strep is that it's still an exquisitely sensitive organism. So it has not developed resistance, although it can cause quite severe disease. We often have good antibiotics to treat it that are very well tolerated. But just the nature of the disease, it's a difficult battle to fight for sure.
Thank you. This one was for Dr. Doan as well. There was a question about brand name versus generic drugs, and if there's a preference and why.
So for the vast majority of medications, and the pharmacists may have a different take on this, from a physician perspective, the vast majority of drugs, generics are just as good. Okay, there are very few exceptions where that's not the case, but by and large, I would say generics are fine, and you don't need to have the trade name drugs. So I'd be interested to see if any of the pharmacists, since I'm vastly outnumbered here, would say something.
I'm getting the stare, so. I do agree. There are certain medications that actually have a unique release formulation. So they're coated with something, and then that releases first, and then it absorbs water in your gut, and then that further releases more medication. So depending on the release mechanism of that particular tablet or capsule that you're taking, it may or may not affect it. So it's better to ask your pharmacist if you have concerns over brand name versus generic, because they may be able to explain that particular tablet, particular mechanism more specifically to you.
The fillers are different.
Well, no,
the fillers that they use are different.
You're right. So
I've had a negative impact on fillers.
So depending on what allergies you may or may not have and how you absorb, and as Dr. Doan has also said, every individual is an individual, right? We can't treat you just like everyone else, but majority of the time, they are. So some people are very sensitive to certain fillers and they need certain brands And it doesn't necessarily have to be brand name, it could be generic as well. I've had patients come and say, I want a very particular brand, and it wasn't brand name. So it could be just that tablet and how you react and how you absorb it. So like, it's different for everyone. It's one of those things that we can't just blanket statement for everyone. Let's see here. There was a question about the, I think, schooling for a technician. You want to try to find that piece of paper, but it was about how, what kind of education did you need to be a, it says pharmacy assistant, but we're talking about technicians today, so.
So to be a pharmacy technician and enroll with the Ontario College of Pharmacy, you need to go through a certified program. I went to Centennial College. It's a 2-year program, and there's hands-on experience as well as theory taught, and that's about it. You go through the program, then you write your PEBCs, so that's a certification with the Pharmacy Board of Canada, and then we register with the Ontario College of Pharmacy.
That's good, thank you. A couple questions that I can probably answer, and they're quite straightforward. One is, what is more important, the drug name or the DIN? I have to say both. I know that's not really a good answer for the person who wrote this question. The drug name is important for your healthcare team. So if you have the DIN, which is a drug ID number, it's important for the pharmacist because they can identify, like that gentleman had mentioned, specific brand and what drug and what dose. But if you give that to a doctor or a nurse practitioner, they can't really do much with that unless they go online and search for it. And search the DIN, which will associate with the name. So in order for a physician, let's say, to look at a list of medications, if you have a whole bunch of DINs for them, or the ID numbers for them, it may not be as helpful, and your appointment may take a little bit longer for them to truly see what you're on. So I think both, depending who you're visiting. Okay?
Good for the insurance company.
It's good for the insurance company. That's what the gentleman has said. That kind of leads to the second question that I found here, and they were talking about insurance, and it very generally, I don't want to talk specifics because each insurance plan, especially the private insurance plans, are very different. And the question was, why does a technician or a pharmacist have to bill through your insurance plan in order to tell you if it's covered or not? Private insurance plans, especially those who are dealing with like an employer, for example, here at Sunnybrook, they employ a pharmacist. If I were to see if that particular medication is covered, I would have to bill it through because every single employer has a different formulary and different list of drugs that were covered. So I can't say that because it's covered for me, it'll be covered for you. Yes?
A follow-up on that question, so that was my question, I think.
Oh.
Is it the computer system of the Pharmacy Association that you guys access, or do you actually get into the particular insurance company every time you do that?
You have to deal with the insurance company.
So whose system you actually go on at that point, when I come in with a prescription?
It's not, there's multiple levels of adjudication. It gets a little more complicated, but you can actually come talk to me afterwards, just so that, I don't know if everyone's interested in exactly the levels of communication, how we adjudicate and how people get paid and everything. It's a little bit deeper and into detail that I think most people may want to get into. So come find me afterwards, we can talk about that. But in terms of coverage, the one insurance plan that as pharmacists and pharmacy technicians know the most about is the one that if you're over 65, we call it the Ontario Drug Benefit Plan. And that's blanket pretty much over for anyone over 65. So that one we can explain to you to very, very fine detail. But if you have a private insurance plan, it's a little harder for us. Okay. There was a question about busyness of the pharmacy. If the pharmacy is so busy, how can they do all these expanded scope of practice? And it takes a lot of planning. But as technicians, as Tricia had mentioned, technicians can now sign for prescriptions, which means that as a pharmacist, I have to check therapeutics for it, but I can leave it for repeats. I can leave it for a technician to check, which frees me up to do more clinical things. For example, like training, injections, and things like that. So it's a matter of figuring out the time and the workflow of that pharmacy and to really maximize the use of the people that you have in the pharmacy. I'm going to pass this to Dr. Dome because I think with the generics vaccine that's come out. It's the question that everyone has. So the question is it necessary to get the vaccine, the Shingrix vaccine, if you've already had the shingles shot, which I'm assuming it says the Zostavax?
So the bottom line is this, that the new Shingrix vaccine is more effective than the older Zostavax vaccine, which is the one we were giving before. So the Shingrix vaccine can be given if you've had Zostavax before. It needs to be at least 8 weeks after you had the Zostavax one. The Shingrix vaccine is 2 doses, 2 to 6 months apart. So it's sort of 85% effective as opposed to the other one, which was 60% effective and a little bit less as you got older. So the bottom line is, should you get it? Probably yes. It's not currently covered. It may be down the line. I can tell you also a little bit, and I found this out the hard way myself, is that the side effect profile is pretty high. And after I got a fever and muscle aches, I went to look it up, and the risks were between 25 and 50% for muscle aches, fever, flu-like illness, etc. So just beware, don't do it the day before you're planning to go somewhere fancy or important.
Thank you, Dr. Tope. There was a question also, I think maybe a second to follow up, is do you or I as a pharmacist would challenge a doctor or a surgeon or a prescriber's opinion when they're prescribing antibiotics and pretty much anything else, I would say. And I don't know if you have any experience with a pharmacist asking you, are you sure you want to do this? And what your response would be.
So yes, I have had that happen before. So the bottom line is pharmacists are integral people in the healthcare team. So oftentimes if a pharmacist questions me on a dose, they're right. Okay, sometimes they're not. But it's a question of physicians, for the most part, will prescribe within norms of prescribing and what's recommended. There are some clinical indications, and I'll give you an example. So when we prescribe antibiotics to young kids with ear infections, we go usually quite a bit in excess of the usual dose. And that's what the guidelines for us say, but it's not what the big manual that the pharmacists use says. So sometimes there are differences in opinion based on that, but I'm always happy to hear from the pharmacist. I would much rather have a pharmacist who's on the ball and checking things and calls me out on something than one who just prescribes something if I made an error and lets it through. So that is the pharmacist's role, to call us out if we do make errors, and we're obviously people and we do make errors once in a while.
Thank you. That kind of follows with the next question, which...
Let me just add one more thing to that. The other thing is sometimes the pharmacist knows other medications that you're taking that I don't know about. Okay, apropos the conversation I had with you before, where I said they might know what you got given by your cardiologist or your respirologist or emerge. I haven't yet gotten a letter from them to let me know what they put you on, and the pharmacist might actually know, and that's a key point to why it's important to use one pharmacist, because then they can keep track of everything that you're on, and the pharmacist will put everything into a big computer system, and they'll see if there's interactions that I might not even know about if I don't know the other meds you're taking.
I absolutely agree with that, and that also accounts for all the conversation about medication lists. I always encourage my patients to carry a medication list in your wallet, in your purse, and if you have a spouse, carry your spouses with you as well. Because just in case something were to happen and the doctor says, oh, what was your spouse on? And I don't know, the pills are at home, then you can just say, this is the most recent list. And the pharmacist is actually really good for that, to help you get everything together. There was a question about antibiotic stewardship and how it works outside of the hospital. How does a pharmacist and, say, a family physician work together to make sure the antibiotics aren't misused?
So I'm looking to Dr. Dong for your opinions as well. It's a little, communication, as you know, is hard to facilitate, especially after hours. But there's always a conversation. If whenever the pharmacist is filling a prescription, if they have concerns, then they will, and it's not pointing out or pointing fingers, it's having that conversation and learning the rationale and whatnot.
So, I mean, I would agree with that 100%. And I think where it's challenging is the pharmacist doesn't have a way of knowing what the indication was or whether or not it was legit for the physician giving you a prescription for an antibiotic. So you can come in and say, well, I had a sore throat, and you can tell the pharmacist that's why I was given the antibiotics. But you don't tell the pharmacist, well, I also have a cough and runny nose and congestion, and all of those other things, and I twisted my doctor's arm to give me a prescription for antibiotics because I'm going on a trip tomorrow. Okay, so it depends on how fulsome a story the pharmacist actually gets. So at the end of the day, most of that interaction about whether or not you're taking antibiotics appropriately or not is between the physician and the patient. And the reality is this, that I'm sure you guys realize this already, physicians have different thresholds in terms of giving antibiotics and how much pressure they'll succumb under from the patient, in fairness. Right? We've got patients all the time that come to us, I've got a cold and I've got this, I need antibiotics. And I tell them, no, you don't need antibiotics, it's not actually going to change anything for your virus. Some patients are very, very insistent. Some doctors would rather write the prescription and get them on their way than end up with a 15-minute conversation. It's not the right thing to do, in my opinion. But some patients don't understand or don't want to listen to the rationale because they'll say, well, last time I had a cold, I took antibiotics and it got better. Well, they don't think about the fact that it would have got better even if they didn't take the antibiotics. But all of a sudden, the antibiotics fixed the cold. So that interaction has to happen between the physician and the patient.
Thank you, Dr. Young. This is more for, I guess, myself, or maybe any of the pharmacists on the panel can answer as well. Why is there not a central registry to keep track of medications, no matter where it is filled? If you are an OHIP, if you're an Ontario Drug Benefits person, or you're 65 and over, you're part of the Trillium program, or you're receiving monthly cards, then yes, there is a central registry that has most of your medications. This depends on what is covered under the formulary. So for example, if you get something for sleep that's not covered and you have to pay out of pocket, is not on that list. So that's why when Tricia was mentioning the best possible medication histories, or BPMH, the technician takes multiple sources. They will go to the drug profile viewer where we'll see your list of medications, but we know that it's not necessarily complete. We will call your pharmacy to see if we can get the rest of it. We may look at your medication vials and see if there's anything else that's missing. And we will actually even look inside those vials, because I don't know if you're guilty of it, but I've seen it myself, that you take 4 different medications in the morning, so you put it all in one vial that's labeled with one name on it. And then when we open it, we're like, oh, there's 4 different pills in here. What are you taking? I see some of the smiles in the room because you see it, and then that's why we start to question, well, what are you taking? Do you know what you're taking? And then also, are you taking it at the right time? So that's the first one. And it says some doctors don't grant refills to their prescription because they want you back in to see them. And depending on what it is true. Some things need to be monitored a little more regularly than others. And I can't comment on doctors' practices because every doctor has a different practice. But majority of the time, if you don't need to be monitored, and Dr. Dome can probably speak to this as well, we don't want to see you every single month or every 2 weeks, unless you need to be monitored on a more regular basis. Maybe Dr. Dome can answer more than that.
No, I would definitely agree with that. I think the vast majority of us are more than busy enough that we don't need patients to come in just to get their prescriptions repeated, but we generally will bring you in if we need to either check your blood pressure, check your diabetes, do lab work, etc. to follow up. So it's certainly reasonable from a patient perspective when you're there to say to your doctor, when do you next want to see me? When do I next need to have something done? If they say 3 months, and say, great, do I have enough medication here to last me? Did you write me prescriptions to last me at least until when I come back? And that's a very fair thing for you to ask. Okay, there's no reason if they don't need to see you for 6 months that they give you a prescription that lasts for 3 months.
Thank you very much. And a little bit about pharmacist extensions. There's quite a few questions about it. So the first question was, what authority does the pharmacist have to refill a prescription that if they can't reach the issuing doctor? The authority is more so it's granted from the law that was passed. I don't know if that was what the person had meant in terms of the authority. And we don't have to renew that prescription, depending on what it is. It's an assessment that needs to be done first. So is it appropriate for us to renew your prescription? Is it something that you need to be on for a lifetime? Or is it something that's less chronic and is, acetaminophen or Tylenol that you can probably get over the counter for a bottle and you'll be okay for the next little while? So it depends on what it is, and it's like I said, the pharmacist does have to do an assessment first. So if you're stable on your medication, of course we're not going to say, you know what, we're not going to renew your prescription. We're just going to let your blood sugars go really high and potentially end up in the hospital. Obviously there's thought process involved as well. The renewal of prescription is not isolated to Ontario. It is across most of the provinces now. Ontario is one of the last provinces to actually jump on board. The western provinces, so BC as well as Alberta, have been on board for quite a while now and have expanded the pharmacist scope quite a bit. And yes, pharmacists can extend prescriptions even if there are 0 renewals, which is what extension technically means. If you have refills, we're going to fill your refills. Okay, we're not going to extend your prescription if you have refills. There was also a question about the responsibility of the pharmacist when we fill prescriptions from different doctors. As Dr. Dome had mentioned, there are multiple people have multiple pharmacies, and that makes the job of the pharmacist actually a little bit harder, especially if you pay cash for your prescriptions. If a prescription runs through an insurance plan, at least there's someone who's keeping tabs on your medications, and there's different alerts that come up, and we can see those. But if you go to different pharmacies, what happens is there may be an interaction that you're not aware of. And that pharmacist doesn't know, just like the doctor wouldn't know that you're on the prescription that was from your cardiologist or that you filled down the street because they were open 24 hours. So if you're not open with that conversation of saying, you know what, I don't feel bad about it. I'm always saying, please tell me what you're on so that I can maximize the amount of interactions I can minimize. So if you're open with your pharmacist and with your doctor, you really are benefiting more from the healthcare system than if you say, you know, I don't want to tell you because I feel embarrassed that, you know, I filled it at Joe's pharmacy instead of yours. Don't be embarrassed, because we need to know. As pharmacists, we need to know, and as physicians, they need to know as well. All right. Oh, I have a question here about supplements. Supplements and supplements that you see in pharmacies. So how many of you have been to a pharmacy that has an aisle full of supplements? And how many of you stood there for about half an hour trying to figure out what you need to take, right? So it's one of those things where you hear on the news or someone on TV that's very famous that says you need to take this now because it's going to benefit your life for the next 2-3 decades. You have to figure out who that is. And like Dr. Dome was mentioning, you got to figure out where that source is and where that research is coming from and who that person is. You know, read that biography before you actually, you know, read those little tabs kind of thing. So the question was about supplements and how pharmacies or pharmacists are trained to give advice. We are trained to a certain extent. So I graduated about 11 years ago, so it was a little while ago. And so back in the day, we weren't really trained on supplements as much as we are now, because supplements are such a big part of what people take. So when we ask people, what medications do you take? We don't just ask medication, we ask, what supplements do you take? What eye drops do you use? Because each and every one of these things you may not think of as medication. You may think, oh, it's just a lubricating eye drop. But what if you're using a lubricating eye drop along with your glaucoma drops and using both at the same time? That dilutes your glaucoma drops, right? So you gotta be aware that you gotta tell everything that you're using, whether you're ingesting, whether you're putting eye drops in, whether you're as a cream, okay? You gotta let us know about it. But yes, just to answer that question, the supplements, we are getting trained a lot more about that. This one goes to the antimicrobial stewardship pharmacist. It's more about antivirals. So the question is, what about antivirals or it asks for antiviral antibiotics. I don't know if there's such a thing as antiviral antibiotics that I'm aware of, but you guys may be a little more familiar with that. And I'm guessing just treatment of viruses, colds, flus, that kind of thing.
So the question is, what about antivirals or antiviral antibiotics? So there are medications that we use against viruses. I'm sure we've all heard of Tamiflu, which we use for the flu, and we have good effect with that, especially with patients who are a little sicker. There are antivirals for other viral caused diseases, for example, cold sores, etc. And we have those, and again, we use those judiciously when we need them, because they have side effects and resistance eventually as well.
Thank you very much. I'm going to give this one to Tricia because it's about blister packs. And so there's a question about charging for blister packs and if it costs additional fees for people who get them.
So every pharmacy is different. Our M1 pharmacy, we do not have a blister pack filling fee. We do charge your copay. So if you are an Ontario Drug Benefit Senior and you pay $2.83 or $4.11 or $2 for each medication, we will charge you that just once a month and then provide you with a month's worth of medications. Other pharmacies may have different practices, and I can't speak on those ones.
No, thank you. So Tricia's right, every pharmacy does have a different practice, so your pharmacy may not charge, but technically speaking, blister packing is not an OHIP covered service. Just like your vaccinations when you go to doctor's offices, I think certain things are not OHIP covered. So it's just because you're an ODB recipient, it doesn't mean that they're covered. Most pharmacies don't charge, some pharmacies do. So it's kind of a non-answer because you have to ask your pharmacy specifically. A little bit about travel vaccinations. Someone asked about obtaining travel vaccines without prescriptions. So even though as pharmacists we can inject the vaccine into you, you still need a prescription. Okay, so there's certain ones that still require a prescription. And if you need advice on travel medication, so for example, if you're traveling to Southeast Asia or if you're traveling overseas and you need some advice, the best people to go to is either your family doctor or a travel clinic. So they will look at the specific region that you're going to, and also you will have to get that information from them.
So speaking of that, just want to put in a plug that most family physicians, myself included, do not have the resources to keep on top of all the epidemics happening in every little corner of the world. So I myself, as a physician, I go to the travel clinic when I travel with my family because I want to get the best advice. Travel clinic medicine is actually not even covered by OHIP. So my suggestion to you, if you're going to be traveling anywhere outside of North America, is go to the travel clinic, get some advice, and make sure that you're going to somebody who actually is keeping abreast of the various outbreaks that are happening in different places, and they're in the best position to give you that advice. And most of those travel clinics actually stock all of the vaccines that you would need, and it's a one-stop shopping where you can get the vaccines while you're there. Just make sure when you do go to the travel clinic that you bring with you a list of the immunizations that you've already had, so you don't end up getting duplications of medications that you've already received at your family doctors, like your routine vaccines.
Thank you. There's a question about discarding unused medications. I know some of you may be a little bit guilty of throwing it in the garbage, maybe? No? Okay, thank you. Whoever said no, thank you very much. Your medications should not be thrown in the garbage. The reason why is, where does your garbage usually go? In the landfill, right? What happens to the garbage in the landfill? It goes into the water. And what happens to the water? You drink it. You drink it, okay? Currently, the filtration system does not filter out medications. It filters out everything else, just not medications. So the plant life, everything is affected by the drugs that you put into the garbage. It's the same thing if you flush it down the toilet, okay? So don't think it's any different. Please, if you have unused medication that you no longer need, doses changed, it's expired, do a spring and a fall clean. So go through your cupboards, your bathrooms, everything that, check the bottles. If it's over a year old, if it's expired, put it in a bag and bring it to your pharmacy and they'll dispose of it for you. I think I've seen different doctors also collect expired medications and bring it to the pharmacy, but what I find is over-the-counter things you never really truly throw out. You know, in the back of your bathroom cabinet, you'll have a bottle of Tylenol that happens to expire maybe 3 years ago, but it's still good. It's still good. It's not good anymore. So take it, please bring it to your local pharmacy and they will discard it for you. Kind of leads to the next question about expiry dates. So there was a question about expiry dates of over-the-counter medications and whether they're accurate or not. Yes and no, depending on what it is and depending on where you are. I usually advise my patients never to take expired drugs. And the reason why is because the expiry date is there for a reason. It's like your milk, right? Typically, you would not drink expired milk. Typically, I've seen some, but typically you would. But the thing is, the expiry date is there because after that expiry date, maybe a couple days maybe, but you know, a month after the expiry date, how do you know that medication has integrated into something that may be harmful for you? You don't, and that's why the expiry date is there, right? You don't want to test that kind of thing. It's not like a slice of bread where, not moldy, it's okay, we'll eat it. Medication can degrade into things that might be harmful for you to ingest. So it's naturally not very good to take expired medications. So that answers that one. Medication storage. That is one thing that I think a lot of people do. How many of you store it in the bathroom? Okay. What happens in the bathroom usually? Well, there's humidity in the bathroom, right? So my suggestion is if you have medications, especially tablets or capsules, do not store it in the bathroom. I know that may be the place that you go to, the first place you go to in the morning, but because of the humidity, especially if you shower and if it's not just like a powder room, there's a potential for moisture to get into that pill, and it will start getting mushy. And you'll be coming to the pharmacy and asking, why is my pill mushy? Then the first question we ask you will be, where did you put it, right? Same thing with if you like to keep it on your windowsill. Especially in the summertime, it's bright. It's lovely, you open the blinds, the sun's coming in, it's great. Your pills are also getting that sun. So it might actually degrade the medication. Best place to store it is in a dark, non-humid area. Usually I say kitchen table, because you need your cup of coffee in the morning, so you're gonna make your cup of coffee and then you're gonna remember to take your pills in the morning, right? Okay. Yeah, so example, sunny window bathroom. So those are the two places that you shouldn't keep your medication. There was a question about medication storage and not communicated to patients. I think that may be more pharmacy specific than anything, because usually we at our pharmacy, we try to make sure that you know where to store your medication. If you are inquiring and you want to know, just ask your pharmacist and say, where should I keep this? Should I keep it in the fridge? Should I keep it in the door of the fridge? Or should I keep it in the back of the fridge? Should I just leave it at room temperature? And once I open it, can I leave it at room temperature? Is that okay? So just ask your pharmacist, because it's drug specific. So for me to answer that question, it's going to take too long. All right. I think there's some questions that I didn't answer because they're a little more specific, and I'm going to leave it for later, or for Paul, our navigator. Well, we have a little bit of time left, I think. Yeah, so is there any question that you wanted to share with us, and then I can, yeah.
So when I was growing, I just wanted to ask about inoculations for children. When I was younger, many years ago,
Not too many years ago, right?
they spread, and I remember they spread the booster shots of the different diphtheria and all those other shots over a period of time. I understand now what they do is they put them all together and shoot them into the kid. And I'm wondering, is there a profound effect on the immune system of a person to have to handle 6 or 7 of these at the same time, as opposed to 1, 2, 3, 4, 5? And tell me if I'm right or wrong.
So what you say is partially correct, but substantially not quite right. So yes, we've amalgamated a few things together, but there are still multiple different vaccines for kids. And when you say what we've done is instead of we've put, for example, one vaccine has 5 things in it. Kids still get some 15 or 18 vaccines by the time they're 6. So there are still many vaccines, but what's changed between the time that you were inoculated as a kid and now is we're inoculating for a lot more things than we used to. So we've had to combine them. Otherwise, so normally now at 2, 4, and 6 months, so for example, a 2-month-old comes to see me, they're getting 2 shots in the legs and 1 thing in the mouth. So if we divide, and one of those things covers 5 different things. So we couldn't possibly take those 5, have those 5 all as separate different vaccines in different times. So kids right now, the normal vaccine schedule is 2, 4, 6, 12, 15, 18 months, 4 years, 6 years, and that doesn't include the flu vaccines. So there are a lot of vaccines, and some have been amalgamated. Okay, we've actually been added vaccines now in grade 7 and grade 8. We're inoculating for a lot more things than we used to. Now, we've lost a few of the things that you probably got inoculated for as a kid because those illnesses have largely been eradicated. So there are less things now, but overall there's more. Does that answer your question?
Somewhat, but there is a delivery system for each one of those injections, right? You can't just inject the drug on its own. There has to be some kind of
A vaccine is actually not really a drug.
okay.
Okay, so when you give a vaccine, it's basically they're what we call inactivated and live vaccines. So an inactivated vaccine is essentially dead particles of that particular illness that are getting injected into somebody. And what it does is it stimulates the person's immune system to create antibodies to that particular thing, so that if they did come in touch with a live version of that, they'd be able to create an antibody response against it. So it's not actually a drug, but it's inactivated particles of that illness. Yes?
I've heard two different stories on basic like aspirin. I've heard that it never expires, and then I've heard if it smells like vinegar, it's expired.
Just because something smells different, it's not, whether it smells different or not, I usually go with the expiry date on the bottle. The reason, I don't know where the story came from, where things don't expire or things expire after a certain smell. I've had multiple brands of different tablets that weren't expired, and I've smelled every single one of them, and they all smell different. So it depends. So it's hard to say. So depending on the manufacturer, they may use something different, as that gentleman had mentioned, different fillers or different ingredients, or maybe it's fruit flavored instead of no flavored. So when you smell tablets, it's not a very good indicator of whether something is expired or not. To be on the safe side, it is your health. So I always say, please just follow the expiry date. Yeah. Lady over here.
I take 5 different medications, so I have 5 little bottles, okay? And I'm wondering, why are pharmacies not taking those bottles and recycling them? It's such a big problem. You look at all the people and all those bottles.
So,
Here,
let me repeat the question. So the question is, you have old bottles at home. You have 5 different medications you're taking. And why can't the pharmacy reuse that bottle? Why can't the pharmacy go and take that bottle and fill that bottle with the same pills you've had for the last 10 years? The reason why is because of safety, okay? We at the pharmacy have a standard of practice that we need to make sure we dispense to you exactly what we know is in a clean bottle. We don't know what's inside that bottle. We'll have to sterilize it, clean it, that kind of thing. So we don't know what powders have been. And some of you know that sometimes you put other things, 5 different pills in the same bottle. So for safety reasons, we don't. It doesn't mean you can't recycle them. Okay, all those plastic bottles are recyclable. So what I suggest is finish your medication, take it as directed, take it every day if you need to. Once that bottle is done, either take the label off. Okay, it's your confidential information, so be careful with that, right? Take the label off or scratch it off with a big black Sharpie, and you can recycle that. Okay, so don't throw it in the garbage. I know it seems very wasteful, but it's for your safety as well. So take the information off and put it into recycling. This is very important for that.
Put it in the blue bin.
Blue bin. Lid, no. Okay, whether you have a snap cap, a safety cap, they all could go into recycling. There was someone over here who also had a question.
With all the changes that are going on, are there continuing education requirements for both pharmacists and technicians?
Yes, so for example, for injections, all the pharmacists who are injection certified had to be trained first. So we had to go through a course, 15 modules, quite a few hours of training. And then you also had the practical aspect. So a nurse would come and watch you inject your buddy who you brought to training and make sure that you can do it properly and with the proper technique. So there is training involved. Technician-wise, they also go through training, not as official, but they will go through regular checks. So checking prescriptions, doing that stuff, yeah. Yes?
What do pharmacies do with medications or partial bottles of medications that are brought back by customers?
The question is, if people bring back medications that are expired, they don't want them anymore, what do pharmacies do with them? The pharmacies are, our pharmacy, and all pharmacies it should be, take the vials, okay, to make sure that if you're returning it with your labels and everything intact, we will take the same thing as you would, take the label off or scratch your name off, okay? Take the bottle and we usually open it up and we actually dispose of it in our medication waste. So medication waste gets incinerated, okay? And so it doesn't get into our water system and it doesn't get into the landfills, okay? That bottle, without your name, will get recycled into the blue bin. Okay? If there are narcotics, for example, you had a surgery and you have some pain medication and you're returning to the pharmacy, as part of our policy, part of Health Canada policy, we have to document that we're destroying your narcotics. Okay, so if we're receiving narcotics from you, we have to document that we destroyed it, who destroyed it, and it has to be signed by 2 people in the pharmacy. So it's regulated quite strictly. Yes?
Might seem like a silly question, but if you drop some medication on the floor, a pill or 2 pills or more, should you instantly discard them or can you wash them off and retake them?
So it sounds like a 5-second rule question. 7-second rule question.
Depends how clean your floor is.
I know. That's what I was going to say too. Depends on, I mean, my suggestion is if it's 1 or 2 tablets, I typically say just leave it. To pick it up, put it into a container that you don't need anymore and bring it back to the pharmacy. The 1 or 2 missed tablets in terms of dropping on the floor, the pharmacist typically understands that, it happens. My suggestion is, and I've seen this before, do not take your tablets over the toilet. Okay? It sounds really silly, but I've had more than one patient come back and say, I dropped all my pills in the toilet. And it just becomes, okay, well, what happened? Why were you in the bathroom taking your tablets when usually you go in the kitchen? So that's one of the reasons why sometimes we'll fax the doctor and say, patient has dropped all their tablets in the toilet. And we suggest, either if you're chronically doing that, maybe getting a blister pack so that if you drop it, it'll just kind of land on the toilet seat instead of into the toilet. But, all jokes aside, it's just a matter of where you take your tablets, right? Just making sure that you take it in a place where you're less likely to drop it into a wet surface, or if you want in a little bowl. I have a patient who has blister packs who punches it into a huge bowl. Because the tablets are so small that she can't see them, so she punches them all into the little bowl, or the big bowl, and then she gets them up. Okay.
2 questions. When our children were young, you had to wait 48 hours for the results of a strep test. And oftentimes they needed the antibiotic and they suffered, they couldn't swallow, and they were at risk from streptococcus bacteria. Has anything changed? Is it a faster turnaround time now?
Okay, so let me address several of those things. So number 1, they were never at risk within 48 hours of the streptococcus bacteria. So when we look at complications of strep throat, so when we're looking at things like rheumatic fever, kidney problems, etc., those take weeks to develop. It's not 48 hours. So the gold standard still is a proper throat culture. Okay, so it's sent to the lab. We have rapid strep tests now where you can get a result fairly quickly. It can be done in the doctor's office in 5-10 minutes, but they're only about 80% sensitive. There's actually been good studies looking at the criteria that we use for diagnosing strep throat. So it's not, so we take an educated guess when we're examining. So there are specific criteria, and when I'm talking about that, we ask about fever, whether there's swollen lymph nodes, whether you have a cough or other signs of a viral illness like congestion. So we actually try to look at the whole big picture to try and figure out the likelihood. And depending on how likely it is, we will often treat right up front before we get that result back if we really think the likelihood is very high of that person having strep. That being said, in the adult population, 90% of sore throats are viral.
I had one more question. Is there still some contraindication for taking with some blood chemistry medications, like for lipids or whatever, grapefruit? Because I heard about it about 30 years ago. You mustn't have grapefruit of any kind with certain parts.
It depends on which ones. So you can't say, so I think the biggest one we call is Lipitor or atorvastatin. So there's certain ones that still have that indication. Depending on which research you look at, some say you can space it out, some say you can't. But typically, we say just for the safety, and we don't know how that medication is metabolized or broken down in their system. So it's safer to not risk it. Certain medications, certain cholesterol medications that you were talking about are okay, but it's best to ask specifically for that particular drug. If you really love grapefruits and you really want to have grapefruits, have a discussion with your doctor as well and say, I really don't want to cut my grapefruits out. Which cholesterol medication can I use? But also you have to think about what is the doctor's goal for you and what is your goal as well. Because if you say, I love grapefruits, but your cholesterol is not coming down with the cholesterol medication they've given you, they may want to give you a statin or something that actually is more effective, but you may have to cut out grapefruits. So you kind of have to look at, you may like grapefruits, but I also like to not have a heart attack. So it kind of, you have to look at the pros and cons of the two. Okay. We're kind of closing in on the, one more question and we'll close it up. Yeah?
To qualify to be a registered pharmacist, how much education? Like how many years at university before you...
For pharmacists, not a technician. For pharmacists? For pharmacists. Pharmacy school in Ontario has changed a little bit since I graduated. Sorry, clarification? Okay, so I graduated, like I said, about 10 years ago. Back in the day, I can say that now. Back in the day, it was a minimum of 1 year undergrad university, and then you can actually apply to pharmacy school, and you have 4 years of education. Now, the program at U of T anyway, Waterloo I'm not really sure because there's 2 different programs. At U of T, so you have at least minimum 2 years undergrad, then you also have 4 years of schooling, the last year of which is clinical rotations through hospitals, community pharmacies, drug information centers, things like that. It's a little bit different now.
And you get a doctor.
And you get a Pharm D, so you get to be a doctor. I'm not a doctor, but but at the same time, I think there's a lot of merit with clinical experience as well. So when you've been working for a little bit of time, you get a little more exposure to certain things. And that's why even though, you know, Pharm Ds come up with a Pharm D, they will still rotate with us as bachelor graduates because we have been working and we have a little more clinical experience that way. But that's why they're doing the clinical rotations. All right, I know a lot of you may still have questions. I want to leave a little bit of time for you to come up and ask your individual questions. But I want to thank all of our incredible speakers today for the great presentation. We'll all be available for the next couple of minutes if you have any further questions. And before you go, just a few housekeeping things. I think some of you are up and leaving. But just to recognize the importance of learning from our patients, we want to remind you that there is a personal health navigator that we have available to you. And there's a weekly blog that you can actually go and read. So former journalist Paul Taylor, who's actually here today, publishes a little blog, a blog every single week about healthcare, how you navigate through healthcare, and I know he's asked me a couple questions, and he's posted as well, so he's a great wealth of knowledge. His email is askpaul@sunnybrook.ca. And please, the orange forms that you see on your chairs, that I see some of you handing in, please do hand them in. They're evaluation forms so that we can actually make sure that we continue to improve our speaker series. And last but not least, there is a free parking voucher. I know, so make sure you pick up your free parking voucher if you did drive today. And we do have upcoming lectures as well. Sunnybrook.ca is the website to go to, and you can actually get your information there. And thank you very much once again for joining us today.